Welcome everyone to this evening's Act Fast Self-Care Forum in celebration of Stroke Awareness Month. Garnet Health hosts virtual self-care forums on a variety of topics to help promote health education and well-being. This evening's program will begin with an introduction of our esteemed panelists and move right into a panel discussion on stroke awareness and prevention. Please consider using the chat box feature throughout the program if you have any questions. The panel will address those questions during the Q&A session at the end. I'd now like to introduce our panelists. Dr. Kaur is our Medical Director of Neurology Services at Garnet Health Doctors and the Medical Director of the Stroke Program at Garnet Health. Dr. May is our Medical Director at Garnet Health Medical Center. Armel Dugan is our Neurology Physician's Assistant for Garnet Health Doctors, and Becky Orman is a nurse and Garnet Health Medical Center's Stroke Program Coordinator. Thanks for joining us this evening, team.
Thank you.
Our first question tonight starts with an alarming fact. According to the CDC, every year more than 795,000 people in the United States have a stroke. About 610,000 of those are for the first time. Panel, what happens when you have a stroke, and are there different kinds?
So I can get started. So there are two different types of stroke. So stroke came from a word where someone like pushed you on the back, gave you a stroke. And that means sudden onset of any neurological symptoms, and usually neurological symptoms in the sense that those are one-sided symptoms. Usually, if someone has an acute onset of headache, sudden onset of headache, vision loss, numbness or weakness in the arm or speech difficulty, that's when we suspect stroke. So strokes can be either from clotting of the brain vessels or bleeding, or that's rupturing of the brain vessels. You have a division of 80% crude numbers of clotting of the blood vessels and 20% almost like rupturing of the blood vessels. And usually we see this in older population, but because of some other factors, we can see this in our younger population, and there are some pediatric strokes even. The most common ones, as I said, are in older population because these clottings and rupturing of the blood vessels happens due to some risk factors that you accrue over time.
I think you nailed it, Kevin. I don't know that, that I can add on to that.
I feel like also our ages are, we used to only see it in older populations. We're seeing it in younger people. So this forum's really great. And the fact that if we can promote wellness and people get the education to people on how to prevent a stroke, we can stop that.
Yeah.
All right. We're obviously talking about self-care here. So that means knowing the risks and the factors and the causes and recognizing the signs and symptoms. What are the factors that someone cannot control when it comes to strokes?
Like the age and the sex, whether they're male or female, those are like factors that they can control.
Their gender, family history. Sorry.
No, go ahead, Beck.
No, their gender, their family history can also put them at higher risk.
Yeah, I was going to say genetics is usually the big thing that comes to mind, where you either know it from your family history, or you may have no idea that you have a family history or a genetic predisposition. And so, unfortunately, if that is in your history, that's something you cannot control for.
Yeah. So these are the risk factors when we talk about, we're not saying that you are biased to have a stroke because of certain way you are formed. It's just that we tend to see more strokes in male population, but females tend to die more of strokes. Their mortality and morbidity is higher due to unknown risk factors. Science still hasn't evolved that much. That's our gender and age, obviously, as I said, because of your risk factors that comes with as the body gets older. That's what means by age. and other societal risk factors in some globally low socioeconomic countries. Because of lack of healthcare system, good diet, they tend to have higher strokes than compared to population of higher socioeconomic status, because it also becomes a form of status, right? Society status. You tend to go out, work out, gymming, and you tend to control your diet. You have access to organic diets. Those are the risk. Those tend to reduce your risk factors in general.
I think people are talking about strokes more now too, which is, getting people thinking about their diets and things that they can do to prevent strokes. I think like a lot of the celebrity news that's coming out, like Hailey Bieber, who just came out and said that she had a TIA recently, which is a mini stroke. Or, Luke Perry was a big loss in the celebrity world, and he died in 2019 from an ischemic stroke.
Yeah, some interesting examples. Unfortunate to the patients, but the reason we give these examples is because you must be aware of those news, and you need to make yourself and your loved ones aware of what stroke is, what can cause stroke, and how we can prevent, and there are treatments out there.
Is like hormones a factor?
Yeah, I think that's why women tend to die more of strokes if stroke affects them. And I will let Dr. Mayer, ED physicians, talk about the contraceptives and all the populations that we see.
Yeah, for sure. So there are different kinds of contraceptions that exist. And so if you are familiar or not, probably the most common that I would start talking about would be oral contraceptives, which is in pill form. So what contraceptives are really designed to do is there's various ways we use them. However, fundamentally what it's doing is giving your body a certain dose of hormone to tell the female body that it is essentially pregnant, and that from either prevents pregnancy is probably the main thing we use it for, but there's other benefits to that depending on other disease entities, which is kind of outside the scope of this talk today. So when oral contraceptives first came out, we had kind of a higher dose of hormone, and also there were multiple types of hormones being used to prevent conceiving or preventing getting pregnant. And so as we've kind of progressed through time, and we've learned that there are some negative side effects to having high dose and also multiple forms of hormone being given through oral contraceptives, modern day oral contraceptives are much safer. However, the way they can manifest as a risk factor for stroke is they may make some women at higher risk for having, one way to say is thicker blood, or that your blood can clot a little bit more easily. And so that's not to say that they aren't safe. They are safe for the large majority of women who are taking them, but they can potentially be a risk factor. Other types of contraception would be implantable devices like a depot shot, which can go in your arm. That's similar to oral contraceptives because it is a hormone. And then there's also IUDs, which come in a few different, I won't say flavors, but a few different forms, which may or may not impact your ability to form blood clots. And so it's kind of a complex topic, but just to boil it down, if you are on any form of contraception, it may be a risk factor for stroke, unfortunately. So.
Yeah, and in younger population, we talk about don't freak out, pregnancy might be a risk factor for stroke, but that usually is pregnancy itself. It's a natural form of making your blood thicken, so nature conserves the baby. Our reproduction is way more important than our brain. That's the only one thing that's more important than brain, not heart or anything else. But pregnancy can unmask other risk factors that you have, that could be clotting disorder that you carry, and it just is not strong enough to show itself unless you have another tendency in your body like pregnancy or dehydration that can form clots in the body, especially if you have any clotting disorder underneath.
Okay, interesting. What factors like can someone control?
Yeah, I can start. One of the big ones would be would probably fall under lifestyle as an umbrella, and so we've already kind of alluded to a few of them. One, which is an ongoing, really epidemic throughout the country, is being overweight. And being overweight by itself is not necessarily the risk factor. It's what being overweight puts you at risk for. And so one of the things, or a few of the things we worry about in someone who is overweight is that sets you up to become or to have high blood pressure or hypertension, which is an abnormally elevated blood pressure, which increases your risk for stroke. It increases your risk to become a diabetic, which is an inability to process sugar correctly through your body. And what that leads to is increased formation of plaques in your arteries, closing off of some of your arteries, can also play into your ability to form blood clots, meaning it makes it more likely for you to form blood clots. And so diabetes would be the second piece to that. And the third piece being high cholesterol, which kind of that trifecta together, high blood pressure, diabetes, high cholesterol, all together increase your risk for multiple diseases, but for this forum tonight, specifically stroke. And so the best way that we've found to kind of get all three of those things under control is having an active lifestyle consisting of exercise. And the recommendation is around 30 minutes a day of exercise that gets your heart rate up around 100 to 130 beats per minute, probably 5 days a week, that's a pretty substantial amount of exercise, even for people who are in shape. But that's kind of the rough guideline of how much activity we should be putting our bodies through to try to prevent diseases like high blood pressure, diabetes, cholesterol. Those are probably the easiest one. Kevin or Becky or Armel, do you want to add anything?
Smoking.
Yeah, so brain is supplied by blood vessels which are below the neck and within the brain itself. So brain just weighs 3 pounds, but it gets 20% of total body's blood supply because it needs all the oxygen because brain is working all the time. So anything that could be wrong with the blood vessels below the neck that's coming from the heart or the body or within the brain, those are the smaller blood vessels that can have hardening of their walls from all the risk factors that Dr. May just described. It will lead to strokes. Those strokes are usually smaller in size, but depends on where the stroke is and how much disability you will get. But the strokes that occur from clotting of or thickening of the blood or any rupturing propensity of the blood vessel from below the neck will usually cause a bigger stroke. And if it's caused in a dominant area of the brain, then you will have really bad disability. So below the neck, meaning if you have irregular beat of the heart, that is atrial fibrillation, you must have heard of. Stenting of the heart blood vessels lead to, in general, risk factors, the hardening of blood vessels everywhere else in the body, and some other risk factors, like some people are prone to what's called sick sinus syndrome that can form clots because there is irregular beat of the heart, either lower or higher beats. Irregular beats, rate or rhythm can be disturbed. So anything that would disrupt the normal beating of the heart or the blood supply is going to form clots and thus cause strokes. But keeping it simple, we can talk about from our nursing perspective, we give education on smoking. Let's hear about that.
Oh yeah, we do try to do a lot of smoking cessation. Smoking, we know, puts you at risk for many different things. Stroke happens to be one of them. Can harden vessels, vasoconstriction. It's going to put you at higher risk. So smoking, in my opinion, is one of the easier lifestyle changes that we can make. You know, we do focus on healthy living and exercising, good diet, but smoking is one of the things that you can stop right away and can decrease your risk.
And we do offer a number of support groups for smoking cessation, not just our center, they're out there in the market. We don't want to be cruel to you or your loved one to say that, okay, stop smoking, that's it, we are the Hitler and you got to listen to us. We are there to support us in any which way. We have some medications that can help. We have some patches. We have some counselings that can be done. So we are there for you in a number of ways. And we can talk about obesity and activity. I will let Armel speak on that. He's very much into running. That can be the easiest way, right?
Yeah, I mean, like Dr. May was speaking, it's recommended if you can get a minimum of like 30 minutes, 5 times a week. And this can be anything from like any exercise that like increases like cardio, like your heartbeats, to like running, even walking, just walking around for like a few couple of miles every single day or every other day, slowly build it up. Like the saying goes, like Rome wasn't built in a day. So if you can begin slowly and just keep ramping up as time goes, and then that helps the heart go up to like 120 to 130 like beats 5 times a week. That reduces your risk for like the obesity, reduces your risk for like stuff like other cardiovascular diseases, reduces your risk for like strokes too. So exercise, yeah, another big life changing that could help.
Just to jump off what Dr. Kaur was talking about, some of the programs we do offer through Garnet, again, we're not the only show in town, but through our own facility, we have a healthy weight program, we have a diabetes program, and then we do have smoking cessation, which Dr. Kaur brought up. And so should you need access to any of these services, we do offer them, and they can be accessed through our website.
Yeah, and for exercise, we don't recommend that you become an athlete in a day. The American Stroke Association guidelines just say that even if you start with mild to moderate intensity exercise, which is defined as 20 minutes for 3 times a week, or you can increase it up to 5 times in a week, and it can be light walking. You can slowly increase your cardio, can go up to jog and running, and those are all helpful ways of lowering your risk factors. The other risk factor would be stress. Nowadays, we get stimulus from all over. So I just heard there was a lecture in one of the organization. We tend to think of mental stress, but we have emotional stress. All these stimuli that we get from text messages, computers, job, colleagues, those are all excessive stimuli to us. So we have to just maybe practice 10 minutes of mindfulness meditation just to relax. We have to work on eliminating, delegating our stimuli. Those are going to be very helpful in small incremental increase, not just, okay, this is going to be done. You form a habit. Habit is formed by doing some exercise or some type of change in your daily functioning for 5-10 minutes, but you have to extend it to 60 days. That's going to form a habit, and that's going to do what's called compound effect, and that's going to make a big change over time.
And to jump off what you were saying earlier about the irregular heartbeat, atrial fibrillation is the second most common heartbeat. Many people do suffer from it. What's important from that, if you are diagnosed with AFib, is to make sure that you stick strictly to your medication regimen. You're being placed on a blood thinner, so because you are at higher risk for throwing a clot, essentially, and that can cause a stroke. So sticking to your medication regimen and following up with your doctor.
Awesome. It's funny. I feel like whenever I start getting stressed, I'm like, oh my goodness, I'm gonna have a stroke. Like that's like the first thing that comes out of my mouth. Can we talk a little bit about like medication management?
Yes, yeah, Dr. May, go for it, because you're the first responder, should I say?
Yeah, well, the first responders come to me, so
right.
So that's a loaded question, and so there's a few ways to look at that statement actually. So Becky started to get kind of into it. When you are being managed with medications for your existing diseases, whether that's high blood pressure, AFib, diabetes, whatever it might be, the biggest thing you could do for yourself, and selfishly, the biggest thing you could do to help us, is to take your meds as they're prescribed. If I would be so presumptuous too, what really helps is knowing what you do take. And I know the nomenclature and the names of these medications can be convoluted, and there's a lot of consonants stuck together that don't really make like words you can even pronounce. And even if you get a few letters correctly, usually we're very good at guessing what it is that you're taking. But the fundamental theme still remains. We prescribe medications to patients to try to decrease their risk for having bad things happen. And so specifically when it comes to the ones we talked about, AFib, high blood pressure, diabetes, high cholesterol, yes, exercise is good, but until you have these things under control, a lot of times you need medications to help you. And so these medications are prescribed at set times and intervals that do the best they can to help you and your body kind of live as long as you can and as healthy as you can. So knowing what your meds are, knowing how to take them and taking them are all huge steps to that. And then how that plays into stroke is if you are compliant with these medication regimens, many people go on to not experience the consequences of their diagnoses. So if you take your blood pressure meds as prescribed, you eat well, you try to avoid salt, you try to exercise, and you keep your blood pressure at a normal level with all these things working together to help you, your chance of stroke goes down. If you have high blood pressure and you kind of slip up on some of these things or choose not to take your medications, then everything we're trying to do to help you kind of goes out the window. And so that's unfortunately when you meet me. And I'm really not someone you do want to meet. I'm happy to take care of anybody, but my job is to take care of you when you're having a bad day. And so if you're seeing me, usually it's not a good thing. And so what Dr. Kaur is alluding to is, people will come in with stroke symptoms, and I see there's a lot of questions pinging about what the signs and symptoms are of stroke. We are coming to that, I promise. And then what happens though is you'll come to us, and the first questions out of our mouths are going to be, what meds do you take? Because that gives us insight into your risk factors, and it helps us to kind of stratify you into, I think you're very likely to have a stroke or a heart attack or whatever it is you might be coming in with. And if you are not taking your medications, that kind of changes what we need to do for you or what we can do for you at times. So we need to be open to having a dialogue with you. If you come in as a patient, we're going to look to you to really kind of walk us through your health. And we're going to ask very specific questions that help us really do the best we can for you.
So to that end,
Yes.
I used to educate my patients and even my family that a really great thing that you can do for us and for yourself, I was an ER nurse before I became the stroke coordinator, was to have a little card that you laminate in your wallet where you can have a list of your medications. Dosages would even be great. Emergency contact, your medical history. It's a very high stress situation when you come into an ER. You may forget things that are really important to us. Also, it's one of the things with having a stroke is you may be what's called aphasic, which means the inability to speak. We can use your card right away and see exactly all the important information that we need to know. So that is something to think about, especially if you have a lot of medications, just like Dr. May said, some of them are really hard to remember. And, you may take a lot of them, that one that you may forget may be very important to us as providers. So the best thing you can do is keep a list and have an emergency contact, somebody that we can call directly, who's going to know your history and be able to make decisions for you.
And speaking about medication, sometimes even when we have the medication, if we have a detailed documentation of the medication, it helps us try and see what you've tried before. And if, let's say you had a stroke on a medication, then we can switch to different medication because we know you've tried this in the past and you had a stroke on it. Maybe we should try and figure out a different medication for you. And so that gives us more information to go to.
Yeah, there's a course that I want to present in front of you. So one thing I tell my outpatients in clinic when I have more time to have leisure talks, most of my patients come to me for leisure talks. That just reduces their burden of seeing a physician. But there's no shame in knowing or asking the care team multiple times what medications you are on and what it means and how you're supposed to take. We are not big fans as providers of Google Doctor. So Google Doctor gives you half information, and half information is very dangerous. But this is one topic where I would say that if you don't understand, if you have there are so many limitations, many barriers to understanding what a provider is telling you. Go on Google, research it. We can provide you information as to what your medication means and how you're supposed to take. Ask more so we can provide you more. So medications are there to lower your risk factor. And simple medication, some patients might say, oh, is that it? Just baby aspirin and just a cholesterol lowering medication? And maybe if you have blood pressure, that's it. Is that all for preventing stroke? Yes, that is. Knowing your medication helps you if there are very few treatments for stroke. So if you are not able to, and there is a time limit. So if you are, God forbid, having a stroke and you present to the emergency department, knowing your medications may make you eligible to get that magic drug, which is a clot buster, right? So with all the medications, if we don't know your history, and as Becky said, if you have deficits that can limit your verbal output of what medications you are on, you might not be able to get that treatment, which is life-saving. And then later on, as Armal said, that we have to tweak in. So our job as stroke providers is to, yes, you had a stroke. Now our job is to make sure you don't have another stroke, because once you had a stroke, your chances of having another stroke is the highest compared to other population. So how to manage you and how to best prevent further stroke is going to be guided by what medications you are on and you are taking. So as simple as just letting us know you're on baby aspirin. What does it mean? If you have 100 questions, ask us.
One of the things that can probably put this all together, though, is really the anchor to like your whole healthcare throughout any system is your primary care provider. And so you should have established care with a primary care physician or provider, whoever it is you're seeing. This is really where their job becomes hugely important. Their job is to kind of keep you on track of this. These are the things that you may have diagnoses for. These are the ways that we are managing it, primarily through medications. You can even have them provide you a list of your meds. If you're finding it tedious to keep track of them or you're not sure, that would be a good starting point to be like, you know, what are my lists of medical issues? What are my surgical problems? If I see anyone other than a primary care provider, like a cardiologist or a nephrologist, we would like to know that information, especially in the emergency room. But they can help you to work through that list. And like Dr. Kaur said, even at any time you interact with healthcare, that's the ER, that's in the hospital, that's in an outpatient office. If you have questions, ask us. A lot of times, especially because we're trying to be very efficient with our time, we assume that you know what we're talking about unless you question us. So if I say, you know, you understand me and you don't, and there's no prompt for me to explain further, I won't. But if you stop me, I will answer the question. And so I would encourage you and empower you all. This is your health. This is your body. Ask questions of us. That's really why we exist. And challenge us. Like, we spent a lot of money on our brains. Challenge me to use it every day. I mean, that's what I want you to do, is stop me and say, hey, I don't know what this is. Can you even pronounce it? And if I can't, then I'll give you $1, you know, but if nothing else, you're forcing me to do my job. That's why I exist. So please, and I'm sure I speak for all you guys, I want you to ask me questions.
And even before your visit, if you have a follow-up appointment with your primary or with your neurologist, you're going to have a lot of questions. And it's, again, one of those kind of stressful situations where you don't know what they're going to tell you, your results. How are you doing? Write down your questions before you go. It's a really great tool, writing these down. Even when you're in the hospital, I used to always tell my patients, you have questions, write them down, because when your doctor's in front of you, that's your moment, because you may not get it again until your next visit, or you're going to have to call and wait for a call back. So the best thing you can do is be prepared, is have your list of medications, have your questions ready.
All right, well, I think it's time to start talking about signs and symptoms of stroke.
Yeah, who wants to start? Should I start? I'll start, because so there's all different ways to recognize signs of a stroke. But the easiest things that we want you guys to remember, there's a mnemonic called FAST. It's FAST. So these are the quick and easy things that if you notice something's wrong, it's time to come to the hospital. It's time to come see me. All right. And so the first thing would be F. F stands for face. And really what we're looking for, or what you should not what you should notice, what you may notice that would be alarming is half of your face is drooping. It could be from your smile, it could be the side of your eye, it could be the way you're blinking, it could even be the way your tongue is moving in your mouth. So there's different ways that this might manifest, but really something is abnormal with one half of your face. So that's the first one. A would stand for arm. You'll see sometimes what we make patients do is we'll make you hold your arms out in front of you. What we're looking for is one arm might not even move, or it may come up and then slowly fall back down. But for you in the community, if you're noticing one arm is not working correctly, that would be a second red flag. Third one would for S is speech. Speech is any difficult getting words out, and that could be you feel like you have like marbles in your mouth where you can't pronounce the words that you want to, although you can actually speak. Or it can be I'm trying to speak and nothing's coming out. That's from the patient perspective. For a family member, noticing someone who may be having a stroke, the other way it may manifest is they may be speaking kind of inappropriately, where you're asking them a question where the answer should be yes or no, and they go on to talk about something that's very nonsensical, where their speech makes sense, but what the words they're saying to you do not make a coherent sentence. And so again, there's a few flavors to this, but if anything is off with their speech, that should be a red flag, and you should be calling an ambulance for to bring them to the hospital. And Dr. Kaur kind of got into this a little bit, but the T in FAST stands for time. Brain and really any organ in your body, but your brain specifically, because it consumes so much oxygen, because it's such a vital organ and it's running full steam pretty much all the time. If there's a lack of blood to your brain cannot survive for very long. The time frame we have for intervention for most strokes is within the first, I'll say 4.5 hours. Kavneet, is that okay?
Yeah, the medication, and then we
Yeah.
have the plumbing system that can be done until 24 hours.
Correct. So there's two numbers you guys need to know, and I'm not trying to get ahead of myself, but Dr. Kaur had alluded to there's really very few treatments we have for someone who's having a stroke actively. Those two treatments come in the form, one is a medication, and then one, Dr. Kaur alluded to, is like a plumbing job where we can go into the blood vessel and actually remove a blood clot. So just to break, we'll talk about that just in 1 second. Let me finish the FAST mnemonic though. So it's F-A-S-T, F for face, A for arm, S for speech, T for time, and the time frame is usually 4.5 hours. What that means is we need to know when your symptoms began, if possible. That even includes if you went to bed. So say I come in at 6 in the morning, I notice when I woke up, I have slurring of speech. That's why I'm in the emergency department. The first question we're gonna ask is, when did you go to sleep? And we don't need to know that it was like 11:03, but around 11 o'clock, and then we can then figure out, can we do anything for you? And what we can offer, if you're within the right time frame, which is 4.5 hours from when your symptoms began, there's a medication we can put into an IV into your arm that will actually dissolve the blood clot. There's two options. One is called alteplase, one is called tenecteplase. The names, again, don't matter, but what they do is they can actually dissolve the blood clot that is giving you your stroke-like symptoms. We have to give that in a certain time frame, because once we go beyond a certain time frame, the risk of that medication becomes too great. It can potentially cause life-threatening bleeding. It can cause potentially other issues like swelling of your mouth. But the risk of that medication becomes too great, so we actually will not even be able to offer to you as a therapy. So that's why time is hugely important to us, especially your stroke team and the emergency department. The other treatment, actually, I've been talking a lot. Let me kick it to Dr. Kaur. This is really more your ball of wax. So I'll stop talking for a minute. Go ahead.
No, great. Thank you, Dr. May. So a sudden onset of any such symptom, and some people also tend to forget that if your balance is off, if your vision is gone, a sudden onset of headache, which is not your normal headache. You might be suffering from headaches, but if there's a sudden onset of headache, sudden alteration of consciousness, that means you're not acting yourself. Anything which is sudden, that just came on, should give you a suspicion that, am I having a stroke, or is my loved one having a stroke, or anybody on the street is having a stroke. We tend to say that it's better to overreact than to underact, because again, our limitations in medical science right now, still in this century, that we have very minimal treatments, and those are bound by the time of when your symptoms started. And not to forget, our healthcare system still has a lot to grow. We are on the route of making it fancy, that we have now, some centers have stroke ambulances where the CAT scan and the team comes to you, but way to go for that. So you have to make sure that you call ambulance right away, so ambulance is able to take you to the appropriate hospital who can provide you stroke care in a timely manner. And that's why all the state healthcare societies or Department of Health has those time limits for us. We are a primary stroke center. We have our metrics. When the patient hits the door, we have to get CAT scan within this time. We have to get the team within this time. We have to get the treatment in within this time. So those are there to just fine tune ourselves, but people having stroke are the major limitation or the deciding factor as to will we be able to help them. And then the plumbing system, I say it because our blood vessels are kind of like plumbing, right? So we all know about cardiac catheterization. The similar way, now the neurointerventional guys can puncture your blood vessel in your leg or your arm and get the catheter in, so blood vessels have no pain sensation. So it's a pain-free procedure. It can be done under local anesthesia nowadays. So the plumbers, they go in, neurointerventionalists, sorry, I don't mean to demean anybody, but my counterparts, I'm a medical stroke neurologist, my neurointerventionalists, they go in with a catheter, they reach up to where the blockages and they retrieve the clot out. That is again going to depend on how much brain viable tissue is left for them to save, because once the tissue is dead, we can't do anything. If at all, we'll be doing more damage because the tissue is dead. So those are all the things that we are able to do, and there's more and more research coming out in Stroke Society. We are now seeing more and more treatments, but still they are under trial phase, research phase. So more to come, but these are the current treatments out in the market.
You touched on one point that I want to just back up and reiterate. The reason why we try to simplify the symptoms we're looking for you to identify in the community for stroke is because, like Dr. Kaur was alluding to, like it could be a vision issue, it could be a balance issue, it could be dizziness, it could be headache. There's so many ways that stroke can present. We're trying to give you the easiest ones to remember.
And the most common ones.
Correct. But what I want to drive home to you guys is don't be bashful or don't be embarrassed about pulling the trigger to call 911 or to present to an emergency department, urgent care, or wherever you are going. What happened? Got it. Don't be embarrassed by, you're nervous about your symptoms. It's your perception of something's going on with your body or your loved one's body. Bring them to us and then let us figure out if we think, actually this is real, and let's go forward and let's try to manage this. Sometimes people come in and it's a complete, it's completely benign. People come in with blue fingers and they just bought new blue jeans, and so it's literally just dye on their fingertips and they think that they're dying. I'd rather deal with alcohol swabs wiping off blue dye from your fingers than you staying at home and missing a stroke. We've all been kind of subject to this pandemic, and one of the biggest negatives medically that the pandemic has done to our system, it's made people scared to come to the hospital, or made people kind of pause and be like, you know what, let me go to bed and let's see if when I wake up, maybe this will be gone. Please don't do that. Call us, come to us. We exist. We're open 24 hours. We're here because these things happen at all times of the day. So I just want to encourage you guys, if you see something that you think is wrong or you feel something is wrong, let us check you and let us validate, or let us, say like, no, this is completely normal. There's nothing wrong. I'd rather have a discussion in the emergency department where I have options to offer you than a month later or a week later when I have nothing more I can do for you. So I just wanted to say that part out loud. That's hugely important.
Yeah, and I think there's this thing in the society where people think that healthcare providers could be judgmental. I'm going to give you an example. We have given all stroke treatments, all possible stroke treatments in the world in an aggressive manner to a 110-year-old patient, because the patient was fully functional, was fully intact here. So we are not ageist, sexist, no judgments. If you think you're having a stroke, it's better to come to us so we can assess you, treat you. If not, we will tell you, hey, you're perfectly healthy, go home. So at least you'll have a good night's sleep. That's why we hold this accreditation of primary stroke center, where Department of Health and the companies, DNV companies who are assigned by New York State Department of Health to come and test us. And those surveys that we go through are not easy ones. We just had ours. They test us that do we have the ability to perform all the testing and everything? Our teams, are they competent enough to provide stroke care? So we are there waiting for you. Don't lose your health. You get this human body not easily. So come to the hospital and get yourself checked. Or outpatient, right? Come to neurology office if you think after stroke, you gotta see a neurologist. You have to make sure that you are on the right medications, even if we don't do anything new, but we have to make sure that you are on the right medications, right treatment, you're seeing the right doctors.
So we're starting to get quite a bit of questions from our attendees. I'll put it to you guys. Do you want to start answering some questions, or do you want to address, life after stroke, or what happens when you present to the emergency department for a stroke?
Let's, I think.
Yeah, I think there's a question, so we can personalize it, right?
Yeah, it sounds like we could probably start with a question. Is there one you want to start with, Mara?
No, whatever works for you guys.
I think I'm just seeing the top ones that came in. The one question asked, I think we can just tick that off real quick. Stephanie had asked, does your chance of stroke increase with age? Is it more prevalent in young people or older? We had talked about that at the beginning, you may have missed. So just to recap real fast, generally an older age puts you at higher risk of stroke. However, we had talked about that we are seeing them occur in younger ages for various reasons. So I just wanted to answer that in case you had missed that piece. We had talked about easy way to remember sudden signs of a stroke. That was the fast mnemonic. So I hope we answered that to your liking, Christina. And then how long do strokes normally last? I guess, Dr. Kaur, that would probably be best addressed.
Sure, yeah. So strokes have, there is right now with the, sorry, I hope I'm not echoing, but if you present on time and you are able to get the treatment, we have seen cases who get better right away, but that doesn't mean that this is it. After stroke, your nerve cells have up to 3 months, if you had a clotting stroke, based on your risk factors, to recover, because the other reason why centers become primary stroke center is because we have definitive stroke units. So we admit the patients there, and that would mean that you get rehabilitation services as soon as you are admitted. So that would increase your chances of getting the rehab done. Either it's based on your deficit, and that's how you get the get back to your normal.
Hey, Kevin, you're breaking up a little bit, so I don't mean to talk over you, but just I think people are missing a little bit. Yeah, you're in and out. So just let me just recap what you did go over. So what Dr. Kaur is talking about is she had mentioned about being accredited. And so within the state and actually on a national level, stroke is something that's followed very closely through like the government regulatory agencies. And so what they do is they come and they challenge us to take care of a patient with stroke. They do that in a few different ways. It's very rigorous. Ours took 2 days, probably 3 days if you really look at everything, and they come once a year and they test our system and see how well we do taking care of patients who suffer from stroke. One of the pieces that Dr. Kaur is bringing up is once you come in with a stroke, one of the things that makes us a stroke center is our ability to give you rehabilitation immediately. And what rehabilitation services do is try to improve your outcome should you have weakness or numbness that is long lasting. That continues during your inpatient stay should you be admitted to the hospital. That also occurs on an outpatient basis, which is also available through our system. But that does kind of pour into one of the other questions, is how long do strokes normally last? And what Dr. Kaur was speaking to is, if you come in immediately with stroke symptoms and we treat you, we have seen patients who get better within their emergency department visit, which is usually about like 3 or 4 hours. Our marker for improvement from stroke, though, is usually not until 3 to 6 months after you've had your stroke. And so that's when we measure you officially, like, do you have long-lasting deficits? How profound are they? How debilitating are they? Will they last the rest of your life, or will they recover mostly? And so it's actually a long time that we give your brain to recover. So I hope I summarized that appropriately, Dr. Kaur.
Yeah, and if you are having a bleeding stroke, you may have up to a year to recover from stroke. But we can't forget why we keep bringing this topic up is because stroke is the #1 cause of disability and #5 cause of death in United States and globally. So it has all the propensity to give you disability, especially if it affects your speech, or if you're an artist, it can affect your arm, many things that could be disabling for yourself way more than what would be for other persons. So it's very personalized. So strokes can last forever, but the symptoms that you come in with, and if you're given appropriate treatment, and even if you don't get the emergent treatment, if we do work up to make sure we prevent your risk factors and we know why the strokes occur, and we prevent you from having next other stroke, that's called recurrent stroke, that will guide what stroke symptoms you're going to end up with and how your functionality will be.
I think it's really important that we talk about this 3-month marker, because I know many times when we talk to patients in this acute phase, the hardest thing is they want to, it's been 3 days, I'm not seeing progress yet. Knowing that you have 3 to 6 months, or in, a bleeding stroke, a year, knowing that you're going to see that progress, keep that motivation, sticking to rehab, sticking to your follow-up appointments are going to be your best chance of seeing that progress over that time frame.
And now the Stroke Society recommends now that we are more comfortable with managing strokes. Previously, it used to be stroke patients have to be bed rest 24 hours after stroke and after certain treatments. Now, no, as soon as you enter the hospital, you get your bed. We recommend that rehab assesses you and move you out of the bed so you can start working out.
Right.
What happens if you're out of time by the time you get to the hospital, and what will be the rest of your life look like after a stroke that was too late to be treated, Darlene? So I think it's not necessary that game is over if you didn't get on time to the hospital and didn't get the acute treatment, stroke intervention. Our job is to make sure that we know why the stroke occurred, and we have to prevent those risk factors and give you that treatment. And what will life look like after stroke? It can be normal or it can be disabling, but obviously that wouldn't mean that it's end of life. As I said, it's the #1 cause of disability and not death. So you most likely you won't die of stroke. There are bigger strokes that can lead to death. That's why it's #5 cause of death. But one factor which we keep in mind, which is very common, is patients are prone to depression. So we tend to pick those signs immediately as soon as, and we start the treatment. And there are many trials which suggest that starting the treatment makes you motivated to work out and do the exercises so you can get your strength or deficits better or back to normal. So it's not end of life, but yeah.
I was just going to say, I interpret that question a little bit differently from Darlene. What happens if you are out of time by the time you get to the hospital? The way I'm interpreting that, and I'm not trying to put words in your mouth, Darlene, but the way I'm reading that is, is it worth coming to the hospital if you're not going to get there in time for treatment? And the answer to that question is you should still come to the hospital. And that's kind of what Dr. Kaur is alluding to. So if you have signs and symptoms of a stroke, you should present to a hospital as quickly as possible. If for some reason that can't happen, you didn't realize right away, some people live alone and don't realize they have any weakness going on, Some people, it happens while they're asleep. There's a lot of variables here. You should still present to the hospital, because even though we can't give you the clot dissolving medication, or we can't do an intervention on you, which is what Dr. Kaur is talking about, the plumbing, where we do a catheterization to try to retrieve a clot. Even if those are not options to you, there's still reasons why we keep you in the hospital. Primarily is one, to figure out why it happened to begin with and what we can do to prevent the next stroke from occurring. The other piece is, if you've had a stroke, you're at risk for having another stroke in the first 48 hours after the first stroke. And so we want you under close watch. So should you unfortunately get a second event, we're there and we can intervene. So there's a lot of reasons why you should still present to the hospital, even if you've had stroke symptoms 2 or 3 days. Say you're away and traveling, or there's some barrier to you getting to medical care, still come. We will still take care of you. There's still work that we can do to help you.
And we have no problems doing the hand holding. Please come.
I think there's like we just
Yeah.
kind of addressed the, do patients recover after stroke, or does it depend on the severity?
Yeah, it depends on, so recovery, I think, has a few different meanings. If you mean, does everyone get 100% better after stroke? The answer is no. However, recovery takes a few different forms, which I think you've been hearing us talk about. So depending on which part of your brain is affected by the stroke dictates what your symptoms will look like. And then depending on how much rehab you go through, and also how many of your brain cells rebound from the stroke, kind of determines what the rest of your life will look like. So we can't always predict that, but we do as much as we can to maximize, or I should say minimize, the symptoms that you suffer from. And then, yeah, after you've had a stroke, how long are you considered high risk of having another stroke? Yeah, go ahead, Kennedy.
Yeah, the first 48 to 72 hours, but we also give you a scale that we use to assess your risk of having recurrent stroke. So now the newest stroke guidelines came out just past month, where we are previously you had a stroke, you come to the emergency department, we keep you no matter what, no matter even if you had a pinky numbness. Now we are very formalized. We have our scoring system, so we are going to assess your risk. If you are not a higher risk, and hospitals tend to be not free of infection, so there are risks within the hospital, especially in COVID, right? So we weigh those risk versus benefits. That's why neurology gets called as soon as the patient hits the door, and we may even discharge you from the hospital, and you will see a neurologist. We tend to give those appointments within 1 week. You see us as outpatient, and we manage you, we do your workup and all those things. But once you had a stroke, you are at way higher risk compared to people who have all the risk factors of having a stroke, but then you just bypass them of having another stroke. So after you're past those 48 to 72 hours, your risk kind of tends to decline. We also in the hospital monitor your blood pressure, your pulses, your heart rate, everything very closely. So we tend to pick up on those risk factors and manage those risk factors sooner. That's why it's important to come to the hospital. So when you are in the hospital, we are passively lowering your risk factors.
All right, well, we're nearing time. We did start a couple minutes late, but there is just one more question that I do have for our panelists here. And Dr. May, you did kind of bring it up, but in a different context. Has COVID had does COVID in general have an impact and increase your risk of stroke?
Yeah, in many ways.
Yeah, you go first. Yeah.
Yeah, COVID, there are some reports where it says that COVID tends to make your blood thickened. So if your blood will be thickened, obviously, as we talked about the pathology of stroke, you tend to, for now, the report says the research is changing every day, that you are at a higher risk of having stroke. But then other risk factors like Dr. Maywood can shed some light on, with COVID, other things happen, right? You become more sedentary. You tend to, I'll let you speak.
Yeah. I mean, so what Dr. Kaur said is 100% true. As COVID, the virus itself has morphed, we're seeing different consequences within patients' bodies from it, one of which could be a blood clot. So that's the first piece. The second piece is how it has impacted your lifestyle. So now we're all fluent in Zoom or WebEx or Google Team or Google Meet, whatever you're using. We're not really going out as much as we used to, although it seems like the last few months that is changing. So becoming more sedentary, having lack of access to your primary care provider, having lack of access to your medications. Some people kind of feel disheartened with the whole system because they're like, the world's burning, and you're like, why would I even bother anymore? And so, fatalism has kind of come into the picture as well. Depression, COVID's kind of touched literally every piece of our lives and every piece of the medical system, in some ways for the better, honest, and in a lot of ways for the worse. And so we're seeing some of the downstream effects of that. And what I had said earlier that Mara is referring to is, reluctance of patients to even present to the medical system because, what are they going to do? Do I really want to expose myself? What if I have a roommate, and what if that roommate has COVID? Am I exposing my family? Or if I come to the hospital, will they let my family even come and see me? That was a big thing. Right now, that is not true. We do allow visitors to come to the ER and to the inpatient units. Obviously, we have to change allowing families to come into the hospital depending on how safe it is. And we're trying to do what we think is best to prevent people from exposing themselves. But a lot of these things make people consider coming to the hospital at all, because, if I can't have my family with me, I'm not going. I certainly understand that. And I understand the reluctance to want to go into a complex medical system where people talk at a level that you may not understand, or they use words that you might not fully comprehend, or you're so sick you can't actually understand what we're telling you. And you usually bring, I usually bring my wife, or I usually bring my husband or my aunt or my niece who's a nurse. They always come and they take notes for me, and that might not be available in a COVID pandemic. I can 100% empathize with that, but I have to stress to you guys, and I think we've said it enough. If you think you're having a stroke or a heart attack, or you think something's going wrong with you, come to us. We will keep you safe. I promise. We exist for a reason. It's to work you guys through what's going wrong with you, and we'll do that to the best of our capacity.
And to that end, with COVID too, the best thing you can also do to help prevent, getting a COVID-related clot is to get yourself vaccinated. We do offer that in the hospital as well. But that's just one of the many ways that you can help prevent strokes, as we talked about. Also, we did touch a little bit on life after stroke. The hospital also does have this great stroke support group that meets monthly. And that's where we used to do it in person. Now it's virtually, but I think we're bringing it back in person, where people who can relate to each other, who have had strokes, can support each other. It's with myself, with the rehab director, and also with the neuropsychologist to talk about those hard things about coping with life after stroke. And it really helps build each other up.
Yeah, and I would just suggest that don't underestimate yourself or your knowledge or your capacity to spread awareness. The purpose of Stroke Awareness Month is that although you think that, okay, I'm going to tell, just maybe if you uttered a word to someone sitting at the bar or a gas station or somewhere, hey, this can be stroke, or did you know about this? I just learned this. We appreciate that, because we are little in number and we can do as much. But if you can be our messengers out in the community, you will do a huge service to humanity.
Well, I was going to say, do we have any final thoughts from the panel? But that was a fabulous message there, Dr. Kaur. Does anybody else have anything they want to share before we finish for the evening? No? Okay, well, I'm going to take a second to share my screen quick and just thank everyone really for coming, and thank our panelists for being here this evening. Should you need a primary care provider or need to see a neurologist and our amazing team here, please don't hesitate to call Garnet Health Doctors at 845-333-7575. And if you'd like to see Dr. May in the ED, or need to see Dr. May in the ED, there's always 911. So thank you guys for tonight, and we'll see you all soon.
Thank you all so much. Stay
Stay
safe.
Thank you guys.
Thank you.